Well, good afternoon, everyone. Are you able to see the screen?
Yes.
Someone, thank you very much. You always wonder, right? So, welcome. My name is Kenley Money. I am with the Arkansas Center for Health Improvement, for those of you who don't know me, sometimes called ACHI, ACHI. And I manage the team that administers the data assets in the Arkansas Healthcare Transparency Initiative, or called HTI, which includes the Arkansas All-Payer Claims Database. This is the quarterly APCD data users group, April 2025, and it is our 23rd group session. Yay. And kudos to those of you who've been here the most. I can't take roll, so all right. All right, let's find the right. Here we go. Today's agenda was developed using data user input. If you have ideas for topics, please let us know, either by entering the ideas in the chat or by emailing us. Perhaps they'll be on a future data users group agenda. I can tell you that one of the topics today, I was in a meeting with some analysts using the UAMS ABI subscription, and they asked me a question. I went, oh, that is perfect for the data users group. So thank you, whoever that was. Some housekeeping rules before we move forward. Again, feel free to type your question in the chat at any time, and we'll address them as we can. I will tell you sometimes I don't see them in the chat, so feel free to interrupt me. At the end of today's session, we will provide a link to our service desk application where you can enter any question or topic that you want to discuss in the future. Arkansas APCD data can be complicated. Those of you who have used it know. You can also request time with our team to address specific questions you have about the data, how to interpret the data, how to manage the data. The data is we always emphasize the value in the data, and if you can't use it, it's not valuable. So we are here to help you. The link to this deck will be provided in a follow-up email that you will receive at the conclusion of the session. More likely it's this afternoon, or at worst case tomorrow morning. That said, a quick reminder, webinar records and presentation material for all the past data users groups are available at arkansasapcd.net. And the link to the deck that you will receive will sort of guide you to that location. If we didn't address a question you have in this session, it may have been addressed in previous sessions. And the way the page is set up, you can see the agendas for all the groups of all the webinars. So you could, it's not real hard to find topics in the library of webinars. You know, sometimes that can be very daunting. You don't have to necessarily watch each one. But I encourage you to review what we've previously discussed. Your answer might be right there. If we have time at the end, we'll have more conversation. We have a packed agenda today, so maybe hopefully we will. And finally, the next data users group is in July 23rd, 2025. We will send out, we'll probably send out a placeholder. You can put it on your calendar when we send out this deck at the end of the session. So let's move forward. I hope that you find today's session helpful. The agenda includes, this is the introduction, some discussion about Arkansas Workers' Compensation Commission data, Medicare Advantage data identification. We have a guest speaker today that will talk, have the featured topic, risk of adverse infant outcomes associated with maternal mental health and substance abuse disorder, future data changes discussion, and latest APCD release and data tips. Our speakers are me, Kenley Money, and our guest speaker is Dr. Claire Brown, Associate Professor, UAMS College of Public Health. So for those of you, I took a quick look at those that have logged in, and you've probably all been here before, but if you haven't, a real quick introduction to ACHI, the Arkansas Center for Health Improvement. We were established in 1998, creating a much needed intersection between research and policy. We are, for all intents and purposes, a nonpartisan health policy shop with proven experience in health data management, analytic reporting and research, etc. The Arkansas Healthcare Transparency Initiative under which is the APCD, was mandated in 2015 under Act 1233. And this data asset has become the premier resource for administrative health data available for research and analysis in the state. And the oversight of the HTI is twofold. The authority comes from the Arkansas Insurance Department. They're the ones who manage the rules, they sign the checks, they sign the agreements. But the administrator is ACHI. That is our role in this. We are, you could classify us as a vendor, but really we are a partner and receive all the data, transform all the data, provide all of the data support for data requesters, and are one of the top users of the Healthcare Transparency Initiative data, including the APCD. And you can see here the HTI integrates these health data to serve many, many purposes. I've talked to many groups and we've had over, I don't know, 150 data requests over the years. Each of them has a different question to ask and answer. And the assets in the HTI include the APCD, the All Payer Claims Database, which includes the administrative health claims, enrollment data, medical claims, pharmacy claims, dental claims. And we've also, that last bullet there, been able to work with partners and link what we call non-claims based data. So birth certificates, death certificates, cancer registry data, medical marijuana cardholder data, some hospital discharge and emergency department data are all linked with the APCD. So you could, in your research and analytics, you could pull those data along with the health insurance claims to address your study question. But there is a source in here in this last bullet, the Arkansas workers' compensation data that we're going to talk about today. So let's move forward. Arkansas Workers' Compensation Commission data. So we've all heard about workers' comp data, right? If you're injured at work, you you would work with your employer to file a workers' comp claim that can help reimburse you for medical expenses, whatever the policy is. And that is through your employer. And but for workers' comp claims that don't get resolved completely through your employer are escalated to the commission, the Arkansas Workers' Compensation Commission, AWCC. And this is a state agency, and you can see here, they receive claims that have escalated that didn't get closed at the employer. And for example, one of my coworkers, and I'm saying this with his permission, he was injured at a team event, shoulder injury. He filed through UAMS a workers' comp claim and took care of it, and it all was fine. But the doctor has said that there is a chance that he might have an additional surgery on his shoulder after a bit of time. So his claim is no longer managed by UMS, it's with the commission because it is still open, and it's been open for a couple of years. There's nothing wrong, it's just that it's open. So try to use that example to describe the difference between traditional employer-based workers' comp and then what happens next. So we get data from the commission, and though they are called claims, they don't look like claims. They don't look like a medical claim. They represent the event more than anything, and they have different fields. They don't have deductibles. They have part of this discussion is to encourage you to go out to the data dictionary and look at the different fields. And it's important to note, because these data don't encompass all of the workers' comp events, it can't be used to understand total employer spend or claims paid for workers' comp, but it has some interesting information that might add a little flavor to your study depending on the question. So I included this slide. I'm not going to read the slide to you, but But the Workers' Compensation Commission takes its job very seriously, and it's been around a very long time. And there's a whole lot of information at this website here about what it is and what it does. And these bullets pull out the difference that I just tried to explain, that it's not at the employer, its purpose is to deal with things that haven't finished, etc. So I won't bore you and read this slide to you. The Workers' Compensation Commission data, AWCC, submits 3 data sets every quarter to us, and with a quarter's worth of data. And these 3 data sets are entitled, you can see here, Claims, Form 2, and Form 4. Well, that's very descriptive. But what they are is this. So the claims data set has data about the injured person, demographics, type of injury, place and time of injury. And when I say place, would be where it hurt, where the injury occurred. Type of injury could be, I don't know, concussion or whatever. But they also have some interesting fields like left foot, right foot, things that wouldn't seem like it was important, but it is as part of the adjudication process when it reaches this level. Form 2 is data about the employer's intent to accept or controvert the claim. And Form 4 is data about the payment. I told you about my coworker who was injured. We have his claim and his Form 2, but we don't have the Form 4 because because we don't know yet when the doctor is going to finally sign off. So the data, if you order this data as a part of a data request, and if you have access to the UAMS subscription through the Arkansas Biosciences Institute or the health department, Arkansas Department of Health, you have these data, but you have all the data. You have, meaning you have events that are concluded. So there's a claim and a Form 2 and a Form 4. We didn't include claims that don't have the other forms associated with it. So it's the whole event. We can change that if you need it, if you decide you want to use these data, but that's how it is right now. So some numbers, just to give you an idea. And you can see the decreasing number, like in 2019, there were 5,422 claims filed, 5,363 got through the employer's intent to pay, and then 4,908 were paid. And that shows you how things go. A lot of things get to the commission and nothing else happens, you can see. Small numbers, very small numbers, but it's a data set, it's data within the HTI that is not widely used at all. Go out to the data dictionaries. There's a link in this deck later on. Take a look at the data elements. Maybe it will be useful to you. And these data are linked to the traditional APCD through the study ID, or AKA the hash ID concatenated with gender. So you can link. All right, so that's Arkansas workers' compensation data. Let's go to Medicare data identification. Any questions so far? No? Take a quick look. No? All right. We'll start here. Quick time check. Hang on. There we go. So I wanted to, this is the topic that was given to me in a meeting that I mentioned earlier in this presentation. What are Medicare Advantage plans? And this is an important topic because in our Healthcare Transparency Initiative data, data requesters associated with state agencies, UAMS, Health Department, any state agency, they have access to the Medicare fee-for-service data that is acquired from CMS. And it's just a licensing thing. But if you are not associated with a state agency, if you are a data requester from anywhere else, then you don't have access to that, but you still have access to some visibility. There's some visibility to Medicare data in the APCD proper. And those are the Medicare Advantage plans. So Medicare Advantage is an alternative to traditional Medicare. And quite often, folks have both traditional Medicare and Medicare Advantage. Because depending on the plan, traditional Medicare will pay for hospital stays where you can buy a plan, but not physician visits. There are many different nuances. I don't want to generalize too much, but they serve the same purpose. They provide, Medicare Advantage provides beneficiaries some different access, different levels of coverage than Medicare. So retired individuals, those who require Medicare, have some choices. But Medicare Advantage plans through private health insurance companies, those companies have to be approved. Blue Cross Blue Shield has some, United Healthcare has some. And you can see here in that third bullet, they cover some of the same services, etc. Medicare Advantage data is inside the Healthcare Transparency Initiative in two ways, with a little bit of overlap. There is the data that is in the APCD that comes from commercial carriers. And then there's the data that is in the fee-for-service, that which we get from CMS through ResDAC, the Research Data Center. We buy those data, and they look different. If you've ever looked at it, it looks different than traditional claims, but all the same information. To find Medicare Advantage data in the APCD, we have done some work for you, and we have identified these carriers and these plans and labeled them in the field ME001CAT. And when that field contains MCR_ADV, that is a Medicare Advantage plan. That way you don't have to go looking for which carriers there are and what the plan names are and this and that and the other. You can shortcut that there. So if you're in the enrollment data in the APCD, look for that value in that field, and those are the individuals, those are Medicare Advantage plans. And then once you have the member IDs associated with those members, then you can go into the claims. In this illustration, we have medical claims, and pull the claims associated. And you'll have to do some alignment with dates to ensure that the claim that you pulled was paid by the plan. There are ways to do that. We can talk about that another time. But that is how you get to Medicare Advantage data in the APCD proper. Now, the Medicare Advantage data is also in the CMS data. Every carrier that has Medicare Advantage has to report to CMS. So for at many levels, we have duplicated data, but the CMS data is carried a little differently and has some different information. Let's see what the next. In Medicare data, if you have had the opportunity on a subscription to look at how, or on some other project, how Medicare beneficiary or member data is carried, it's different than the APCD. It's carried one row per member per year. And instead of multiple rows representing different time periods, say in the member data, that's kind of a broad statement, but you can have multiple rows in the APCD. There are multiple fields that represent months of that year on a Medicare beneficiary summary data row. Whew. Okay. I have a little bit of an example, so hopefully a picture speaks 1,000 words. But if you look at the second bullet on this slide here, it says 12 variables are present on each beneficiary summary record, and their labels are HMO_IND_01, and it goes through 12. And those represent months. 1 is January, 2 is February, 3 is March, etc. Each is a monthly indicator that identifies whether the Benny was enrolled in fee-for-service or a managed care, aka Medicare Advantage plan. Again, you're going to have this deck at the end, but all of this information is available if you search for this on Google at the ResDAC or on the CMS websites. Take you all the way through it. So this is a very simple representation of a Benny record, because a beneficiary record has 100 fields in it. Luckily, it's probably more. But Benny's 1, 2, 3, and 4, and these are all for year 2021. And you can see the rows. There's HMO indicator 01, 02, 03, 04. So it's January through December. Well, that's fine and good, but how do I know which month I was in traditional Medicare or Medicare Advantage? And it's not always just all the year. Sometimes it fluctuates depending on the member's activity. So you see these values, C and 0. What do those mean? That isn't very intuitive, but you can go look at what these values mean. There's the link. Here are the definitions. You see the C and the 0. Let's go down here. Arkansas data has values 0, 1, and C, though less than 1% of have a 1. So it's all 0 and C for all intents and purposes. I haven't done as much work with these data as our analytics team, but I've never seen a 1 or needed to use a 1. So here's our data again. And if you look here, remember, this is year 2021. Value C, this value C equals enrolled in Medicare Advantage. This Benny was enrolled in Medicare Advantage in February of 21. But if you look in March, they weren't. This one, this other Benny, has a 0, which means they were enrolled in traditional Medicare in March of 21, as was Benny 1. But you can see, I'm going to see if I can back up. So that Benny 1, he was in Medicare Advantage 2 months and the rest of the time fee for service. I don't know why, but that's what happened with this person. And Benny 2, there was Medicare Advantage, some fee for service, traditional Medicare, and then Medicare Advantage, etc. You can see how it goes. Another way to look at it is this way, and I just threw this in because if you're a data geek like me, you like to see things pivoted. But it's the same, it means the same thing. So as you go through your work, if you have access to these data, it's up to you if you want to pivot it or not, but know that that's how you identify Medicare Advantage data within the traditional Medicare data. There is overlap. Each version is similar, but has some different information. If you looked at Medicare data, it has a lot, it's cut differently. And which to use is dependent entirely on your access to data and your study question. So here are some overlap numbers. So mostly it overlaps. There are some differences, and the Arkansas APCD data could be sometimes we get plan data from the carriers before Medicare, but mostly it overlaps. And we're not going to go through my code, but I threw this in here in case you wanted to look at how to overlap. When you get this deck, you're welcome to plagiarize my code. Totally different. All right. Are there any questions at this particular time? Oh, here's one. Stand by. Can we link Medicare Advantage data with the death certificate data? Also, do we need additional permissions for 5-digit zips for these bennies? Thank you. Those are both great questions. Yes, you can link the Medicare Advantage data with the death certificate data using the study ID, the AKA the hash ID plus the gender. You totally can do that. And then I'm sorry. Then yeah, you would have to ask for, when you do your data request, you would need to ask for permission to get the 5 digits in. It's not difficult to do, but we do need additional justification when you do that. And then the next question is, are there missing values where they were not enrolled in either certain months? When you turn 65, you're enrolled in traditional Medicare, period. And so there will always be the 0 if it's not. And then, is CCW data available for MA? When you say MA, you mean Massachusetts? What do you mean?
Probably Medicaid. Medicare.
Oh, Medicare Advantage. Oh, thank you. Yeah, it's everyone who's in the Medicare data. Massachusetts, my apologies. All right, anybody else? No, okay. Okay. Then you get back over to my deck. Let's queue up our featured topic. I'd like to introduce Dr. Claire Brown. Claire?
Present. All right, so I'm presenting today on a project that was an offshoot from a KO1 that I have that's meant to build algorithmically fair models for predicting low birth weight. We identified mental health was an important variable, so we conducted an analysis to look at the impact of mental health conditions and substance use disorders on low birth weight. Next slide, please.
Getting there.
And I have funding, and these are my views and not NIH's. Next slide, please. All right, so I'm sure we've all heard of the various large rates of adverse infant and maternal outcomes nationally, particularly here in Arkansas. We have among the worst rates for pretty much every infant and maternal outcome. I'll skip a lot of that information, as I'm sure most of us have heard many of those statistics. What I do want to highlight is the increasing awareness of the impact of mental health conditions on infant and maternal health. It's estimated that around 1 in 5 pregnant and postpartum women have a mental health condition, and around 10% indicate past month substance use, 8% indicate past month tobacco use, and then 11 indicate an alcohol use disorder. Next slide, please. There have been various evaluations looking at the impacts of perinatal mental health conditions. There are some indirect impacts, such as the mental health conditions being associated with lower nutrition and sleep, increased risk of risky behaviors, reduced prenatal care, and then associations with reduced social support. But there's also direct impacts of perinatal mental health and substance use disorders, such as increased cortisol levels, which increase risk of adverse infant and maternal outcomes, and then some direct physiological effects associated with some substances, such as directly impacting the fetal heart rate. Next slide, please. We've done some previous work in this space, essentially looking at the impact of mental health conditions on severe maternal morbidity. All the mental health conditions that we looked at did increase the risk of severe maternal morbidity. Next slide, please. As well as readmission. These two previous studies use hospital discharge data, which is limited to identifying mental health conditions that are present at the time of delivery, or at least noted in the hospital discharge data. So inherently, that data does have some limitations. So we're hoping to use the All Payers Claims database to perhaps better capture mental health conditions than what may be available through hospital discharge data. Next slide, please. On this particular study, we used the APCD 2017 through 2022 to look at the impact of various mental health and substance use conditions. Individuals had to have at least 1 month of Medicaid or private insurance noted in the APCD during their pregnancy period, have at least one claim and not have missing information on key study variables. This resulted in about 125,000 live births and around 7.5 million insurance claims. We included claims from the pregnancy period through the date of delivery. This was largely because there are some women who don't have insurance until they're pregnant, and we wanted to do our best to ensure that everyone had kind of equivalent potential time frame of coverage. The insurance claims that we looked at went back through 2016 because we had to have a look back period for those births that occurred in 2017. Next slide, please. We originally were looking at low birth weight, as I described. There were some suggestions during the submission of our manuscript and review process to perhaps additionally include preterm birth. Some of that has to do with concerns that low birth weight was potentially just capturing early births. So to mitigate the reviewer concerns, as suggested, we ultimately used one outcome of adverse infant outcome, which was either a preterm birth, which is less than 37 weeks gestation, or low birth weight, which is less than 2,500 grams. Next slide, please. We looked at 12 different mental health conditions and 6 substance use disorders. This was based off the previous studies we did, which was based off a list of conditions that were in a ACHI data brief. I'm happy to share that resource. Something must have happened in my citations when I did my design, but I have the references at the end, or I'm more than happy to share any of those references if anyone wants them. Those particular metrics included, like I said, 12 and 6 individual conditions. We ultimately had some stratified analyses for those conditions with a high enough sample size for what we were trying to do, which are those that are highlighted in red. Next slide, please. We had various covariates. I won't go into these in too much detail, but there were demographic, clinical, pregnancy-related, and area-level covariates. The area-level stuff was linked at either the zip code or the county level, depending on what was available for that particular metric and the source that it came from. Those came from the Community Health Rankings data, Area Health Resource File, and the AHRQ Social Determinants database. Next slide, please. So we just used pretty classic multivariable logistic regression with the various covariates that I listed, annual and month fixed effects, as well as standard errors clustered at the county level. We calculated marginal effects, including average, which consisted of average adjusted predictions, and calculated relative risks from those measures. We calculated the relative risk associated with any mental health condition, which was any of those 12, any substance use disorders, which was any of those 6 substance use disorders. For those 2 things, we also conducted analyses with those 2 metrics interacted with race and ethnicity, as well as with payer. And then we additionally calculated the relative risk associated with those conditions that had a large enough sample size. And for those, we did not do the interactions. Next slide, please. So these are the rates of the outcomes, unadjusted. So we had about 22% had any mental health condition, which is that top row there. This is the blue coloring there is the breakdown of the mental health conditions by payer and by race. You can see there were higher rates of mental health conditions among white individuals and among those with Medicaid coverage. When we looked at substance use disorders, that's those highlighted in orange, there was about 9% had any substance use disorder. There are 5 times higher rate among Medicaid covered individuals. And then when we're looking by race, there's substantially higher rates for Black and white individuals relative to those that were Hispanic or other race. Next slide, please. These are the percent of individuals that had each of the specific mental health conditions and substance use disorders that had large enough sample sizes for us to look at more specifically. You can see as we anticipated, the largest percentages are anxiety and depression, but we had some reasonably large percentages for other common mental health conditions. With respect to substance use disorder, about 9% had any, and the most common was cannabis use disorder. Next slide, please. These are the rates of the adverse infant outcome, which again is that combined metric of preterm birth or low birth weight for each of the various mental health conditions. I won't go through all of these, but they all were statistically higher. That probably was because of our reasonably large sample size. The ones that had the biggest, the largest increased risk, and these are unadjusted, is the schizophrenia related condition over there on the blue, which are the mental health sides, and then on the orange side, which is the substance use disorder, the highest rate was for individuals that had a stimulant use disorder. Next slide, please. These are the adjusted analyses. This particular table is just for the overall. On the top row there, we did the interactions by race, and then we did the interactions by payer. So each of these are a separate model. So the overall was one model, the by race was one model that had the interaction term, and then the by payer was a separate model that had an interaction term. Essentially, we see that across the board, having any mental health condition increased your risk of the adverse infant outcomes, with the highest risk for white individuals and the highest risk among payer being those who had private insurance. Next slide, please. With respect to substance use disorder, again, we looked overall and then interaction with race and interaction with payer. We found that the highest adjusted risk was for white individuals and private individuals again. the relative risk associated with increased risk of low birth weight was not significant for Hispanic individuals or for individuals of other race and ethnicity. Next slide, please. When we looked at the specific mental health conditions, we saw that essentially all of the conditions were associated with increased risk, with the exception of the suicidal ideation. The condition that had the largest or the greatest increased risk were anxiety-related conditions, which had a relative risk of 1.28, as well as depressive-related conditions. Next slide, please. With respect to specific substance use disorders, all of them were statistically significant, I guess with exception of alcohol, which was 0.052. But we saw strong associations between the substance use disorders and adverse infant outcomes, the largest of which was, again, for the stimulant use disorders. Next slide, please. Overall, our conclusions are that mental health conditions and substance use disorders do increase your relative risk of having an adverse infant outcome by about 28% and 32% respectively. We felt good that our rates of the mental health conditions and substance use disorders align well with the literature. I have various national citations if someone is interested. We're a little worried that perhaps they'd be underrepresented just because some things are not as commonly captured in claims data as others, but we saw that they align pretty well nationally. We don't have the ability to look at our exact things with other metrics specific to Arkansas, or at least with mental health conditions. We see that same about 1 in 5 rate for any mental health condition. And then our metric of substance use disorder found about 9%, which is pretty close with the past month illicit drug use and alcohol use at 10 and 11%. Next slide, please. So policy implications are essentially just understanding the access and screening for various mental health and substance use conditions across populations. Of course, consider a life course perspective on the implications of mental health. So this is an outcome that the mom has a mental health condition and it's impacting the baby, and that baby will have various short and long-term outcomes potentially associated with low birth weight or preterm birth. And just continuing to consider and advocate for comprehensive perinatal bundles of care that recognize a broad scope of mental health and substance use conditions that should be screened for. Next slide, please. I think that's my question slide. So I'm happy to answer any questions. I kept it relatively short, but happy to answer any questions, or you can email me if you have any questions.
Thank you, Claire. There are no questions in the chat right now. I'll give everyone a second. That I always like to listen to reports such as this to show how well our data aligns. So as always, when you have such large data, I get asked a lot, how does it align with national averages, national, et cetera? And
yeah, we felt pretty good. I mean, it's hard to say because I would assume that Arkansas may have relatively higher rates. So looking at this, if we looked at a gold standard of rates in Arkansas, they may be a little higher. Therefore, our rates using the APCD may be a little low, but we're not incredibly worried about the rates that, we weren't sure how good it would be well it would be documented.
Okay. All right, well, Claire, there are no questions in the chat. I'm sure you'll get a lot of emails. Thank you so much. It's always a pleasure. All right, and with that, I'm going to move on to our next topic. If you attended the January data users group, I announced at that time that we are undergoing a project to update the data submission guide. The data submission guide is the required layout we give to submitters, to the carriers, to send the format of which they must send the data. If you've looked at the APCD data, the tables are very wide. There's a lot of detail there, and periodically adjustments have to be made. And so this year is one of those years we wanted to invite some feedback from our data users if there's anything they would like to see. So we asked a few questions in January. And I've got a few more here and we sent them out. If you pre-registered, we sent the questions out ahead of time and I have gotten a couple of responses. Thank you so much. I'm going to ask the questions again. If you've already replied, don't feel like you have to, that you have to reply again. But I thought we'd just go through them and you can put your suggestions in the chat or you can unmute yourself with an answer or a question about the question, which is totally fine. And if you did not get the email and you would like to do this at your leisure after the webinar, then let me know and we will send you these questions via email. So question number 1, each medical claim represents a service or a visit, this you know. What do you want to know about the event that is currently unavailable? Have you been using the claims data and you think, man, I wish I knew this. I wish I had this. Has anybody experienced that and what might that be? I'm going to dovetail on that just a little bit. How important to your studies is it that you know if the provider were not in this country? Oh, there's a comment, excuse me. All right. I'm getting there. Functional status. All right, thank you. And when you say functional status, what do you mean? The patient's functional status? I mean ADL. Okay. Okay. Thank you. That was very interesting. Anybody else? All right, well, you can still put something in the chat. So in the interest of time, I'm going to move forward. What type of data is required to effectively identify and understand telehealth claims? I've had a couple of data requesters in the past 6 weeks wanting to do studies with telehealth claims. What would you want to know? I can envision a clear flag that identifies a telehealth claim. I'm looking at the chat. Okay. And I wonder if there couldn't be, telehealth is a very broad and frankly an old word because it's not just telephone anymore. It could be video. It could, different mediums and perhaps maybe a flag if it's valuable to know what type of medium was used. Virtual, I don't know. So I appreciate any input on that. All right. What do you want to know about providers rendering services? How would you use the billing provider information? It's on the claim, if you look at remember the medical claim, there's the service provider, the billing provider, and the rendering provider, and there's even organization. And while they're all related, because it has to do with the claim, they may not look like they're related. Is there any of that provider information that you don't use? Does it matter if it's the billing provider? If the billing provider information went away, would that be a problem? I'm not saying it will, I'm just saying. Okay, I mentioned oh, I'm sorry, I got ahead of myself. Currently, I'm going to go to the next question. County code is represented by the 3-digit FIPS code. New best practice includes the 2-digit state FIPS code, for example, 05065. Which do you prefer and why? I've already had some feedback on this, that it's easier to match the state concatenated with county, the 5-digit, to other files, to FIPS data, etc. It's easier to do that if it's all in one field. Does anybody have any feedback or preference? Is it problematic?
I would say most data sources I use have just the 5-digit, but I
Okay.
don't think it's particularly difficult to split it or not. Where I've seen most people who perhaps are newer to using the FIPS code data is that when they pull in data from other sources, they accidentally drop the leading 0 and they're like, why doesn't my data merge at all? But that's not really an APCD. issue, but something that I see some people get stuck on is that obviously all the PIPs in Arkansas start with a 0, and
Mhm.
that can get dropped, so.
Thank you, Claire. Thank you. And I could see that on both sides, that drops the 0 in front of the state and the 0 in front of the county. Although not all counties have, I think some counties don't have.
Some start with 1
Yeah.
here in Arkansas, yeah.
Mhm. Thank you, Claire. All right. Next, there are just a couple more. If available, how would you use information about the frequency of a member's income, monthly, weekly, daily? And the only reason I didn't put this in here to torture people, but there is a national group, the APCD Council, and they have this document called the Common Data Layout, and it is recommended data fields for all APCDs. And it includes this field, the frequency of a member's income. And I never thought about that before, but if we could get that, would that be helpful? And I have gotten some positive feedback on this. And I would be interested if you would want to know what they make monthly, weekly, daily. It's a little problematic because the claim represents a quarter. I mean, it's what the last version of the claim or the information for that quarter. So daily, it could be daily for a little while and monthly for another little while. It's hard to say, but any feedback on that would be very helpful. The next question, how would you use capitated payment information, is too broad for this conversation, but I would be interested in that and how you would want to see it. Some of the references to capitation in the common data layout that I just mentioned read like populate the field as if there was no capitation. Ours are a little more generic, and we want to fine tune it for this particular DSG change. But this last one I would really like. Oh, I'm looking at. Let me do this last question, then I'll get back to your comment. Okay, the last question. I really am interested in this because this could represent a big, moderately big change in the data submission guide, the way the values are captured. Several fields within the current data have the same standard set of values. Is the differentiation valuable, or would simpler values be better? So you can see that table, current, it's broken up into these 1, 2, 3, 4, 5. And a proposed way to do it is 1 and 0. So for you data users, what is preferred? The granularity or generalization? Granular, okay. Okay, yeah. All right. I thought as much, but I wanted to get your feedback on that. I'm going to move my comments over here, so I'm looking at the camera. Great, that's marvelous. All right, I'm going to go back up to this first. Mandana says, bullet related to the providers. I prefer using the rendering provider, as this is the individual who actually delivered the services and was present at the time. Billing provider may not necessarily have been present. Yeah, and I suppose it depends on your question, but I understand completely. The next comment is about the payment, the pay schedule stuff, and it would just be the schedule. It wouldn't be the amounts. If we could get it at all. The fact that it exists in our common data layout makes me think that some carriers have it, but we shall see. Very great information. Anything else? If you did receive these questions ahead of time, I really would value any information that you have to give. And if you would like, I can send them to you. The next comment is, another data point of interest would be out-of-pocket payments made by the beneficiaries. There is an out-of-pocket field, but made by the, we'll take a look at that and make certain that it is useful. Okay. Great. Thank you so much. Again, if you got these questions, I would really appreciate your feedback, and I'm happy to send them out again. All right, we have just a few minutes left, 8 minutes left. Let's, the latest release information is unchanged from January. We do have a new build and it should be ready in June, and it will have data through December of 2024. And it may have a little more data because we were able to start it after, with some carriers provided January through March data, but not too many. So the official time period ends in December of 2024. There will be release notes, universe counts, and earlier when I was talking about the workers' compensation data, I suggested you look at the data dictionaries. You can get to those data field definitions through this link here. And this, I think we announced this last time, but there is a new PBM for Arkansas Employee Benefits Division, Navitas. And this is what the HTI data looks like. You can reference this when you get the deck. And then don't forget your data tips. I hope all of you are on our data tip email. If you are not, let me know, because we send out monthly data tips. Sometimes they're repeated because it's always good to be reminded. And these are the ones that I pulled out for today. We won't go through them, but I do urge you to look at them. It's always important to know the nuances. We tried very, very hard to provide the cleanest data possible, but sometimes you just can't. You just can't get it the way it needs to be because of limitations at the carrier. All right. Here is the technical support link. If you want to send us questions, happy to do it, or inquiries, data inquiries, and send us ideas. If there's a topic you want to talk about, let me know. And there that link is again. Call to action. Next data users group is in July. And that's it. Does anybody have any final question? Oh, I thought there was another one. Does anybody have any final comments? Well, if not, thank you again, Claire, for being our guest speaker. It's always a pleasure. And for the group, go out and use data. And let us know if you have any questions. Thank you so much.